Good morning, everyone. I'm Robert Dempsey, and I'm very happy today to represent FIENS, the Foundation for International Education in Neurological Surgery. This now 54-year-old organization of volunteers worldwide is working to develop neurosurgical care in areas where it was not present before. This is done through a series of educational opportunities, including fellowships, training programs in 4 continents. We're very, very lucky today to have our virtual visiting professor program, which is a combination of trainees and expertise given for participants worldwide. Our topic today is neurosurgical infectious emergencies. We will hear expertise from Dr. Raji Mahmud from Nigeria, but importantly, the program will be moderated by Dr. Lowe, who is one of our Bassett Fellows. This is one of our fellowship programs for education of neurosurgeons worldwide, either in completing their residency or, in Dr. Lowe's case, in postgraduate education. So we're very pleased to have everyone today for this important topic. It will include both didactic and question and answer. So please, for the last 20 to 15 minutes of the presentation, we'll be asking for your questions at that time. Please be thinking of them, and Dr. Lowe will be moderating that portion. But now to start us off, Dr. Lowe will be introducing herself and then our guest speaker, Dr. Lowe.
Thank you, Dr. Dempsey. A very warm welcome to everyone. Thank you for joining us today for this visiting professor webinar. I'm Dr. Lowe, a neurosurgeon from Malaysia, and I'm one of the FIENS Bassett Fellow for year 2022. It's a great pleasure for me to introduce our speaker today, Dr. Muhammad Raji Mahmud, who is going to talk to us about infectious neurosurgical emergencies. Dr. Raji is an associate professor of neurosurgery at the Ahmadu Bello University at Zaria, Nigeria. He is the first African to chair the World Federation of Neurological Societies Young Neurosurgeons Committee in year 2008. He pioneered and established the Division of Neurosurgery and Neurosurgical Training Program at the National Hospital Abuja, and he's also actively involved in a number of global neurosurgery associations, initiatives, and programs. He's currently the Chief Medical Director at the National Hospital Abuja, as appointed by the President of Federal Republic of Nigeria. Without further ado, I'd like to welcome Dr. Raji to start his presentation.
Hello, Dr. Lowe. Yeah, thank you so much for the kind introduction. And I also thank the chairman of FIENS, Professor Bob Dempsey, and Jean, and all the other team and foundation members for inviting me to this program. It is really an honor. As mentioned earlier, this topic, infectious neurosurgical emergencies, is something that should be top amongst the top topics in neurosurgery in our world today, ideally, because of the rising number of cases of neurosurgical infections, most especially in developing world. All infectious diseases affecting CNS are actually of neurosurgical importance, although, as we know, not all of them present as emergencies. Infectious emergencies of neurosurgical importance have been on a steady rise globally, and the worst hit are those countries that are in the low and middle income region. This study was, this has been found out in one of our studies in 2018, which was published in the Journal of Neurosurgery. The outcomes of infectious neurosurgical cases has improved over time due to the improvement in access of imaging modalities, such as the CT scan and the MRI. And also because of the pharmaceutical companies' contributions, they have been able to develop more potent antimicrobials that have higher penetrative capacities into the CNS. So that has also reduced in improvement on outcome. On our own part, as caregivers, we have our skills and techniques have also improved in surgery and anesthesia, and also in critical care. That has positively impacted on the outcomes of neurosurgery. This is the paper I referred to earlier that we published in JNS in 2018, which showed that the mean age of those affected are actually the young people. The mean age is about 35.8. Africa has the highest burden of incidence. The overall incidence is highest, like I said, in low and middle income countries, up to 726 cases per 100,000, which is quite a staggering number. If you compare this against what you see in high income countries, that's just about 11 per 100,000 cases. This is just a simple classification of neurosurgical infections. You might wish to classify them under location. If it could be cranial or spinal. And in the cranial, it can affect virtually all the subsections of the cranial cavity. It could be intraparenchymal, intraventricular, subdural, or epidural. And so also in spinal, it could affect the subdural space, the epidural space, the vertebral bodies themselves, and can also involve the discs. There are various organisms that cause neurosurgical infections. They could be bacterial, parasitic, viral, or fungal, each of them having different subsets under it. Various risk factors give rise to these infections. Some can be congenital, most especially in younger patients, from cyanotic heart diseases and pulmonary AV fistulae. They can also be from acquired causes for those in extremes of ages, from cases of trauma, immunosuppression from HIV, organ transplants, and bone marrow transplants and things like that. Also from chemotherapy because of immunosuppression. They can also come from other infections of contiguous organs of the body, like dental abscesses, endocarditis, from lung abscesses, otitis, and the rest. It can be post-procedural, most especially following craniotomies and laminectomies that have been contaminated at some point. Alcoholism as a habit can also expose or predispose one to infections because of immunosuppression. I won't bore you into the details of physiology of the CNS infections, but what we might need to know is that this could cause cerebral edema, and that eventually gives to raised ICP. And because of the pressure intracranial, there might be reduction in the cerebral blood flow, leading to ischemia and worsening of cerebral edema, and then herniation. That can also give rise to mass effect, either from brain edema or the lesion itself, that's from the infective organism itself, forming maybe a granuloma or CSF outflow obstruction. It can lead to mass effect, which eventually can also lead to herniation. There can be neurotoxicity, either direct toxic insult to the neurons themselves, either in the brain or the spinal cord, or via indirect means where via immune system activation. The cytokines get released, and that can actually hurt some of the neurons indirectly. There are various clinical presentations of the neurosurgical infectious emergencies. They could come in various syndromes like meningeal syndrome and space-occupying lesions with manifestations of focal neurological deficit, features of raised ICP. There could be stroke-like syndromes also with sudden onset of focal deficit and also embolic stroke. And they can also present with skull-based syndromes, orbital apex, like orbital apex syndromes, and also cavernous sinus syndromes. This can actually be even fatal, more especially the cavernous sinus syndrome. Sometimes these infectious emergencies can give rise to some confusion. So sometimes one could confuse them with intracranial tumors or intracranial hemorrhages, obstructive hydrocephalus from other causes, CVD, spinal cord tumors, and traumatic myelopathy. A number of times, some TB spine, if not well investigated, could actually be confused with spinal cord tumor. We have seen intracranial tumors being confused with toxoplasmosis or sometimes even cerebral abscesses when you can get confused with cystic brain tumors. The management here has something like a, I would say, a blanket rule where you do a quick assessment and resuscitation, taking a history, and ensure that the circulation and the airways are quite under control. And then a number of these patients, most especially those with supratentorial lesions, come with seizures. And there are times when the seizures might become almost intractable. So you need to control the seizures, and you measure, take measures to control the raised ICP that most often they come with during such emergencies. Patients with cord compression need to be immobilized so that one does not worsen the cord compressions and cause more injuries. Once the patient is resuscitated, then a detailed history can now be taken, doing a physical exam and do investigations based on what the suspicion of the primary cause is. But basically, blood samples for CBC and differentials could be taken, electrolytes and urea creatinine to assess other metabolic systems. And the random glucose are also taken, the erythrocyte sedimentation rate, and see the active protein. Procalcitonin, which I didn't write here, is also actually quite important, and it's quite very specific for bacterial infections also of the CNS. Cerebrospinal fluid exam is quite essential in a number of these patients, most especially when there is a suspicion of meningitis. One bedrock of management is to identify the source of infection so as to control it, because otherwise one would have a vicious cycle unless the primary source is confirmed. Then the next thing is to have brain imaging as soon as possible. This will help in locating the lesion. I would say if it's a mass lesion, you need to find the location, the numbers of lesions, and if there's associated edema. And also important is to see if there's any vascular structure that is adjacent to where the infective lesion is, because sometimes we do have erosion into those vessels, and that can be a bit catastrophic at times, or emboli can also be sent through those vessels. We need to also note if there's hydrocephalus or any mycotic aneurysm. Okay, then some of the modalities of the brain imaging include CT with contrast, MRI with contrast, and MR spectroscopy. I have discovered during the times of my practice that MR spectroscopy is quite useful in such cases. Like I tried to give an example of sometimes confusing some brain tumors with some either brain abscesses or solid lesions like toxoplasmosis or lymphoma. lymphomas also. So it brings MR spectroscopy has helped significantly in identifying which type of lesion the lesion is likely to be, so that you can tailor your treatment towards that. Then we have, these are just MRIs of, on the left, the two MRIs are those of brain abscess. And then this is someone we treated with aspiration, as when we talk about later the treatment modalities, would mention some of the treatments that can be instituted. And then on the right here, you'd see it's a Pott's disease. We have seen worse ones actually, but you can see here a collection of cold abscess around C5, behind the body of C5 and compressing on the cord. But just below the cord, just below the compression, you see that the cord is also swollen as a result of cord inflammation. So these are typical MRI images that you see. On the brain MRI, you see a significant vasogenic, likely vasogenic edema around the lesion. Yeah, the image on the left of the screen is also some TB abscess, but you can also see that the sinuses or the base of the skull is also involved. This can also be seen in bacterial abscesses, most especially when it's associated with sinusitis. And the pictures of the MRI on the right side of the screen shows the typical punch-in lesions that you see on in cases of cysticercosis. Fortunately, on this part of my world, we don't see such cases, so I borrowed this image from elsewhere. In my practice, I've never seen even a single case of neurocysticercosis. However, I know some parts of Africa are actually, have endemic cases of neurocysticercosis. Treatment is multidisciplinary. It involves a number of fields of medicine, from infectious disease physicians, neurosurgeons, physiotherapists to ENT surgeons. The modalities are mainly medical if there isn't mass effect or raised ICP or anything life-threatening. And then once there is some, life-threatening life-threatening situation, then a number of times we discover that surgical intervention may need to come in. The medical treatment is meant for acute infections, and when there's no evidence of raised ICP, no focal neurological deficit, and no mass lesions on imaging. Here, depending on the organism causing the lesion, you give either antibiotics, antifungals, antiretrovirals, antihelminthics. Most of the patients that come with supratentorial lesions, like I said, significant percentage of them come with seizures. So you might have to cover them with anticonvulsants until you're able to achieve control. There are indications for surgical intervention. This would include raised ICP, when there's focal deficit, when there's significant mass lesion on imaging, and when there's CSF obstruction, or either via communicating hydrocephalus or even non-communicating hydrocephalus, whatever it is that you're able to get, you might do, if there's ventriculitis, you might want to do an EVD and external ventricular drain, or in cases where you do not expect the contamination of the ventricles, you might then divert the CSF via a VP shunt. You would need to obtain specimen in some of these cases, so surgery may be indicated in these cases. And the main aim also of surgery is to have control of the infective source. The options of surgery include borehole aspiration, most especially in cases of cerebral abscess. There are times when you might have to do craniotomy and excision, especially for very large abscesses that are causing significant compressive symptoms. We have done a lot of such. We pull off the abscess to really be sure that you have eradicated the lesion completely. There are deep-seated, sometimes you come across very deep-seated lesions. So in such cases, because of access, you might have to employ the use of stereotactic aspiration. And in the spine, decompression might be necessary at some point when there is significant compression on the cord, or when they are to just allow some space in the cord when there's significant cord edema. This can be done with or without fixation. Once you suspect, when you see there's an obvious instability, or you suspect that there might be instability later in life, then you might have to consider spinal fixation. In acute bacterial meningitis, neurosurgeons come across this quite often, most especially post-procedure. And here you might need to do LP, which would give you an elevated opening pressure, severe hypoglycemia, which is less than 2.5 millimoles per liter. And the WBC count may also be elevated when leukocytes have moved into the CSF. There might be elevated proteins, most especially in bacterial meningitis, of up to over 50 milligrams per DL in most patients. Gram stain may be positive in a not significant number of such cases. Inflammatory markers are important to be run in such cases. There will be high CRP and high procalcitonin, as I mentioned earlier, in such bacterial infections. You may not find such high rise in viral infections. There are times when you have to do a blood culture or polymerase chain reaction to isolate the organism for precise treatment. These are brain imagings of the in bacterial meningitis. Here you see there are some leptomeningeal enhancement, and also there may be some distension of the subarachnoid space because of pressure of maybe the exudates that are produced by those organisms. You can also see at this corner hydrocephalus, most likely from obstructive causes in such cases of bacterial meningitis. Treatment is usually by antibiotics, and you need to, depending on the region and the likely primary cause, you might need to select the antibiotic that is likely most appropriate. Surgery here is you need to evacuate the abscess collection and do CSF diversion in cases of hydrocephalus. The brain abscesses are usually related to infections outside the CNS, from infection of the paranasal sinuses or otologic structures, from lung abscesses, and can also come from endocarditis via hematogenous spread, and also can be cryptogenic in 20%. You do whatever it is, but you may not be able to find the cause of the abscess. The presentation is variable, sometimes not non-specific, with headaches, fever, and vomiting and seizures. And there are times when they become quite specific with deficits and features of predisposing conditions. When you have features of predisposing conditions, that makes life a bit easier for you because you will be able to control the primary source. Diagnosis is done with brain MRI and contrast, and then gram stain and histologic exam of the aspirate. If there aren't compressive symptoms, you might just give antibiotics. But if there are compressive symptoms or signs, then you give antibiotics along with surgery. such as bowel aspiration and then craniotomy to excise the lesion. There's a paper that came out of Zaria a couple of years back, I think way back in 2016, which out of 36 patients that had surgery, 23 of them had boreholes and 6 had craniotomy. And they had a good of such cases. And the overall mortality was not so bad, as about 5.4. Mycobacterium tuberculosis is endemic also in some parts of the low and middle income countries. TB meningitis is the most frequent form of CNS tuberculosis, and it accounts for about 2,500 cases per year in the US, but the highest incidence is in Africa with 55 cases in 100,000. This has increased with the cases of HIV. However, now there is the good news that HIV is more or less, the incidents have more or less stabilized, and hopefully it might go down eventually worldwide and in Africa as well. So we hope to see that TB and TBM cases of incidences have also reduced. The problem with TBM is that it secretes lots of exudates and obliterates the basal systems, and it spreads along pial vessels, thereby invading adjacent vessels. This leads to significant meningitis. So, and there are times when there may even be deposits of tubercles on the choroid plexus. So they present with evidence of hydrocephalus encephalitis and some spinal column invasion and compressive myelopathy at times. The diagnosis is more or less the usual form of diagnosis of Mycobacterium tuberculosis. CSF analysis would show slight glucose in CSF, and then ZN stain would be positive. Bacterial culture is usually negative, but PCR analysis has a high yield in getting, in isolating this organism. MRI with contrast is useful. With contrast enhancement on the basal systems, and occasionally you see frag tuberculoma. And in a number of cases, you see patients have hydrocephalus. Patients are given corticosteroids in order to reduce the inflammation within the meninges and subarachnoid spaces, most especially once the diagnosis is made early. So that would help. Antituberculous treatment is given for quite a long time, at least 18 months. Anticonvulsants are also given because of the incidence they have of seizures. Surgical treatment will include CSF diversion. In such a case, if it's a TB meningitis, you just don't even contemplate passing a VP shunt. You first do an EVD to be sure that at least you're able to clean the ventricles. Because because of the high protein content, once you do a VP shunt, it can easily get blocked. And surgical treatment is done to reduce mass effect and to control raised ICP, and also to treat spine compressions. Viral encephalitis are also common, and they are community acquired most often. And they give rise to intense meningeal and parenchymal inflammation, which eventually results in meningoencephalitis. The culprit organisms most often herpes virus and then arboviruses. Most especially, a typical example is the West Nile virus. Major criteria for diagnosis is patient having altered mental status without any alternative cause that you'll be able to identify. And then at least 2 of the following minor criteria: fever of 72 hours, new onset seizures, new onset focal neurological deficit, and WBC count of above or equal to 5 cells per millimeter cube in the CSF, and new imaging finding and abnormal EEG consistent with encephalitis. Once you have any of the 2 minor criteria plus the major criteria, then you have your a good diagnosis of viral encephalitis. Here, treatment is mainly antiviral medications and immunotherapy for those who have some immunosuppression, and then steroids, because we said it usually elicits intense immune reaction. So steroids can help in at least controlling that inflammation. CSF diversion in cases of hydrocephalus might be imminent. Decompressive craniotomy can be done for patients who have significant or severe cerebral edema with raised ICP. There are times when even the cerebral decompression, craniotomy with decompression may not be able to help, such that one has to do temporal lobectomy for medically intractable raised ICP. We also have fungal infections. The incidence of CNS fungal infections are usually parallel to that of the systemic fungal infections. And common culprits are Seniorformans, some Candida species, and Aspergillus species. The route of entry are the common ones, like through inhalation and through colonization of the nostrils or sinuses. The major risk factor in fungal infections are actually immunocompromised patients from either HIV, medications, drugs, chemotherapy, and even malignancy itself. We have seen a few cases also of malnutrition giving rise to immunosuppression, and some fungal pathogens like immunocompetent hosts. So you and I are not actually immune to that as well. So people need to take try that. Then they can come with emergencies like space-occupying lesions. They can be fungal meningitis, giving rise to some certain sequelae that are similar to those you see in bacterial meningitis. There can be rhinocerebral syndromes and stroke-like syndromes. Here in aspergillosis or zygomycosis, people have reported such often. And also subarachnoid hemorrhage resulting from mycotic aneurysms have also been reported a number of times. I have not seen one yet in my practice, but there are a couple of cases that have been reported in the literature. Treatment can be started with non-specific measures like control of predisposing factors, and then treatment of intracranial hypertension with medical means, and then use of antifungals like amphotericin B and fluclocytosine. And there are new medications now that are undergoing trials. Hopefully they would be more potent than the ones we have and less toxic like as the ones we have now, liposomal amphotericin B and capsofungin and others. If medical treatment is not too responsive, or the patients have come with significant cerebral edema, then surgery may have to come in. Surgery can also be done for diagnostic purposes using stereotactic biopsy, and then you can do therapeutic surgery by evacuation of the abscess, drainage of the parental sinuses, CSF diversion. There are times when Ommaya reservoir may need to be inserted in order to give chemotherapy for prolonged periods of time. Spine, if there is spine compression, spinal cord compression, spine decompression may need to be done to excise granuloma and also to evacuate abscesses. Helminthic infections do occur also as CNS infections. We've seen an MRI of neurocysticercosis. Okay, there are cases where people have hydatid disease, paragonimiasis, schistosomiasis, toxocariasis, and the likes. In neurocysticercosis, the has a burden in Africa of about 650 per 100,000 cases, 100,000 population in low and medium income countries, as reported by the paper we published in 2018. However, one interesting find is that the lowest incidence is found in the Eastern Mediterranean region, where they hardly keep pork. They have a little number of pork industries there. So that means pork in most of the areas that we see these high incidences actually plays a significant role, since it's to the fecal-oral route that is usually transferred. They present with parenchymal neurocytocercosis, leading us to epilepsy as a most common symptom, as reported in humans, and also can give rise to other focal neurological signs, paresis, and the rest. There can also be extraparenchymal neurocytocercosis, leading to intracranial hypertension, frequently associated with obstructive hydrocephalus, and also focal neurodeficit. The mainstay of treatment is medical, and then control of seizures. The drug of choice is albendazole and praziquantel, and usually these medications really do well. It can be indicated if the diagnosis is uncertain, and when there's edema or mass effect that is refractory to medical treatment, or when there is hydrocephalus. Also, when there's intraventricular cytocercosis, surgery may need to be done to take out the cysts. The presence of acute or subacute rise in ICP is an indication for surgery. The options for surgery include stereotactic excisional biopsy or an open craniotomy. We've talked about CSF diversion. When there are intraventricular cysts, one of the best ways these days to tackle them is through endoscopic excision. In AIDS and HIV, the advent of AIDS and HIV has led to a number of and some increase in neurosurgical infectious emergencies. The direct pathways through this happens is via release of cytokines and other neurotoxins by the infected macrophages and microglia on the neuronal tissues. So that gives direct damage on the nervous tissues, or it could be indirect via viral proteins like TAT protein and GP120 that trigger release of neurotoxins from the macrophages and the astrocytes. There also can be impairment of the excitatory neurotransmitters and calcium influx that leads to inflammatory responses. AIDS can lead to some of these syndromes, like viral syndromes of various types of viral neurosurgical problems. It could be non-viral syndromes like Toxoplasma gondii infection, Candida albicans, and atypical microbacterium. CNS lymphomas have seen significant rise with the advent of HIV. And systemic lymphomas with CNS involvement also been associated with AIDS, also Kaposi's sarcoma with metastasis to the brain. We have seen a number of such cases here. Yes. Toxoplasmosis is closely related to AIDS and HIV, and we have seen a number of such cases in this environment as well. Though, as I said, these days the number, because of the medications that HIV patients are taking, and also the preventive prophylactic medications they are taking of Septrin, these cases are not as much as they used to be some years back in this part of the world. but they present with headache, focal neurological deficits, seizures, and cognitive defects. Then imaging studies will show typical peripheral contrast enhancing lesions, which have a predilection for the basal ganglia. And major differential diagnosis of toxoplasmosis in the brain is lymphoma. So that's where the MR spectroscopy comes into play here before you do a biopsy. Toxoplasma, meningoencephalitis, and encephalopathy also do occur, most especially in patients who have a CD4 count of below 200 cubic millimeter. And we have seen a couple of patients also with HIV myelopathy. And here, when you do an MRI, if it's 1.5 Tesla MRI and above, you are likely to see vacuolations in the white matter of the spinal cord, and which is almost similar to what you see in vitamin B deficiency. Usually, HIV myelopathy is a diagnosis of exclusion. MRI or CT may exclude the following. Lymphomatous deposits in the epidural space may also need to be ruled out to be sure that it's not any other thing. Lumbar puncture can also help out, where do cytomegalovirus polyradiculopathy, especially in patients presenting with some spastic paresis. So this as an MRI of a patient with toxoplasmosis who has suffered toxoplasmosis. And as you can see, you might call this a glioma. So, but that's where spectroscopy comes in. So in a number of cases, after spectroscopy, sometimes we have to also do brain, we have to take a biopsy to know exactly what the diagnosis is. Okay. For medical treatment of toxoplasmosis, we give pyrimethamine, and this is followed with other medications. Folic acid is also given to those patients. Once your diagnosis is that of lymphoma, then radiotherapy is what the patient needs to have. And surgery can be done in cases where you would want to confirm the diagnosis of toxoplasmosis or other, maybe a lymphoma also, just to confirm your diagnosis. And well, the other cause of surgical infections is post-operative surgical site infection, but most often these cases are usually superficial and they hardly come as emergencies from our experience here. But in a very few cases, when they present with meningitis, we do treat them as emergencies. Once in a while, you have cerebral abscesses that grow quite large, then you have to treat them as emergencies as well. But most often, they're usually superficial and can be treated medically. And the risk factors for such surgical site infections include repeated operative interventions, poor tissue handling or quality, impaired vascular supply, radiation injury, nutritional deficiency, and then presence of foreign bodies. So in conclusion, CNS infections can cause significant morbidity and mortality. And early diagnosis and prompt intervention is required to improve this outcome, most especially when these cases present to you as neurosurgical emergencies. Thank you so much for listening.
Thank you, Dr. Raji, for the very informative presentation. Next, we'll move on to the Q&A session. Just a reminder to the participants, you can actually put down your questions in the chat box, the Q&A box, or you can actually raise your hand, and we will allow you to on your speaker to ask a question. So far we have two questions in the chat box. So I'll read up to Dr. Raji on this. The first question is, for patients on EVD, what is your strategy to reduce intraventricular catheter-related ventriculitis in a low-resource setting?
All right, thank you so much. Whether you are in a low-resource setting or in a high-resource setting, the principles are the same. So you don't compromise as far as you can. Usually what we have made as a practice here is we pass an EVD and keep it for between 5 days to 7 days. If you still need to continue the EVD, then you change the site to the opposite side. So that's what, and we have found that to be quite good. There are times when, because sometimes patients pay out of pocket, unlike other countries or other centers, parts of the world where healthcare is via insurance. So patients here sometimes may not be able to pay or get the EVD sets as required. So you may push your luck a bit by extending up to 10 days, but we hardly extend beyond 10 days, usually 5 to 7 days.
Thank you for the answer, Dr. Raji. So followed by the second questions by the same attendee. The question is, surgical site infection is a common problem in lower middle income country, especially at centers that have just started their neurosurgical services. So do you have any advice to neurosurgeons on reducing the measures to reduce the incidence of surgical site infection in a low resource setting? Okay,
thank you for this question. Yeah, I think we have had a number of discussions over the years regarding reduction in surgical site infections in low income countries. But I always tell people the most important thing is to always stick to principles, wherever it is you are. Principles of asepsis are the same, whichever environment you are in. So if you have control over the design of your theater, of design of your wards before they're built, then you make sure you get the design settings to be the ones that are acceptable in hospital construction. So you don't just convert a home with louvers as windows into a theater, because there easily things would just bacteria or whatever can just filter into your OR. So once you have that done from construction, then by the time you've already set up the OR, ensure your red line zone where nobody comes in except they are well kitted, and follow the aseptic techniques when going in. Do not overcrowd your theater. And then during surgeries, ensure that you do the steps the right way. Always stick to principles. You hardly will ever wrong when you stick to principles. However, I've seen a number of people, just because they are in the low and middle income countries, they tend to do whatever it is they feel I mean, they're good, and blame it on the environment. I really don't believe that. Thank you.
Right, thank you for the answer, Dr. Raji. So we have a few questions more. I think the next question is from Dr. Ng here. She's asking, for abscess that recurs after aspiration, when do you consider doing a craniotomy and excision? Do you re-aspirate the abscess for 2 to 3 times and convert to craniotomy, or do you just perform a repeat aspirations without conversion to craniotomy?
Okay. Actually, as for me, I aspirate once And if it recurs, I then I give antibiotics. I cover antibiotics, whichever, whether I'm going to aspirate or not. But by the time I am aspirating, I aspirate only once and continue my antibiotics. If the abscess recurs and it's large enough and I have a corridor, it's not deep-seated, I usually go for craniotomy the second time. But if it is so deep-seated that I know I'm going to really violate the brain significantly before I get into the abscess, so that's when I re-aspirate. But most often, you discover that most of this abscess will go more and more superficial as time goes on. So I just do aspiration first, and then second time, if I have to, I excise.
Thank you, Dr. Raji. We have another question from Dr. Jogi here. Dr. Jogi is asking, what is your recommendation for empirical medications or empirical management before the investigation results come back? Because in some of the center, diagnosis may take time for them. So he would like to know what's your advice or what's your options for empirical treatment in this kind of situation.
Okay, that's good. So that's why it's important to take a very good history and do a very good examination. In 90% of cases, by the time you do this, if you've taken a good history and exam, you are likely to know what type of ailment you are dealing with in 90% of cases. For instance, if a patient comes to you with otitis media, chronic otitis media, and then as part of history, but then he has come with what you feel. It has hemiparesis and all. So, and you are likely going to tie it down to, yes, he has a brain abscess from otitis media. So the likely organism that causes otitis media is what? Staph aureus. So you treat that. So also if a patient comes to you, says, okay, I have been having sinusitis for quite a while, the ENT surgeon has been treating me, but now I have this very bad headache and I have speech difficulty and things like that, then you know the likely organism as well. And or a patient comes to you with, hemiparesis, and then severe headaches, blurry vision, but he tells you that he is an HIV infected patient, then your mind will go to, yes, a brain abscess and toxoplasmosis, even before you start investigations. So you try to cover him for both until you are able to establish your diagnosis. So I think taking history and a very good exam are the bedrock of everything in medicine.
Yeah, thank you. Next question is from Dr. Julie Sam. I think Dr. Julie Sam is asking, how do you decide on whether burr hole and drainage or excision of abscess should be performed in a case? I think in the previous questions, you did answer some of the point on this, but do you have anything else that you would like to add on for Dr. Sam?
Yeah, sometimes, for instance, once I see that an abscess is superficial and I don't have to violate any part of brain, once it's superficial and large enough, causing mass effect, I just go for excision from the start. Or when a patient presents with empyema, I just, subdural empyema, I don't bother aspirating, except if I see that the patient is not stable enough for me to prepare him to theater. So, but once the patient is stable enough in subdural empyema, I don't bother aspiration. I just go straight for craniotomy and excision, evacuation rather. Yeah.
Okay, thank you again to Dr. Raji. The next question is from Dr. Afiz Aruna. Dr. Afiz is asking about the timing of surgical intervention in the case of TB spine.
Yeah, in the case of TB spine, we have seen a number of cases of TB spine that have done quite well without surgical intervention, frankly, except if there is worsening instability. If there's instability, yes, you may now go, you may wish to stabilize the spine. So while doing so, you can now decompress the spinal cord as well. But in significant number, I wouldn't want to just quote a number offhand, but probably about 60–70% of patients, the TB medication is effective enough. Anti-TB medications, they're effective enough to really treat the lesion by themselves. In fact, and it's sometimes quite magical. Within a few days, 48 to 72 hours, you start having positive response. Once you place them on the adequate amount of dosage per body weight and the right number of medications. So it's quite magical sometimes.
Thank you very much, Dr. Raji. So now Dr. Ronald. Dr. Ronald is asking about the usage of steroid therapy in CNS infection in immunocompromised patients. I think Dr. Raji did mention just now during your talk that steroids are quite useful in some of the cases for infections. So Dr. Ronald would like to know whether we should use steroid in patients with immunocompromised, such as in patients with HIV or AIDS.
Okay, so you need to treat cases based on each case. Each case is to be treated on its merit. If you see, for instance, some patients may have TB or TB meningitis without necessarily having to have HIV. You get it? So you can give your steroids. And even in HIV, when you give steroids, or in immunocompromised patients, when you give steroids, it doesn't mean that you are giving it to them till forever. It's just for a stipulated period of time to just control the inflammatory response pending when your medications set in. And once your medications set in, then you can withdraw your steroids. Yeah, it's just for a short period of time, a week or 2 weeks, depending on the response of your patient. But if you see that your patient is significantly immunocompromised, that steroids might cause more problems, then please, you do not have to give that steroid. That's why humans are not robots. Doctors need to evaluate each patient based on his or her clinical signs and symptoms and conditions as it is at that time.
Okay, thank you very much, Dr. Raji. I think Dr. Robert Dempsey actually raised his hand. So, Dr. Robert, do you have something to ask, or you have any
Raji,
comments?
I felt that you had a beautiful case which sort of summarizes so many of your points, where you showed the case of the patient with tuberculosis, a sinus source, and a anterior brainstem abscess. I wonder if you could walk us through the steps of multimodality therapy for that, which includes the treatment of the point source as well. If you had a patient, a cranial tuberculosis abscess like that in a difficult position with the use of the antibiotics, the use of surgical decompression of the sinuses, what would your sequence be to work through such a difficult case, since tuberculosis is so common?
Yeah, so in such cases, usually we do an MDT. We call, like in this case, you get close to the ENT surgeon so that he will be able to tackle the primary source or the sinuses for you. And then definitely a neurosurgeon would be there. The pathologists would also need to be there. So, and then the infectious disease expert consultant is also there to advise on the types of medications to give. So first, this patient has a lesion on the brainstem. First thing to do is to see how stable the patient is. Some of these patients, like in that patient, he was more or less stable except for the neurologic deficits that he had. Yeah, so there wasn't any need to say we needed to resuscitate him or anything, but immediately antibiotics were commenced because initially we were not sure of what the cause was. Antibiotics were commenced, And then by the time the ENT surgeon came and was able to take the low-hanging fruit, that's the lesion from the sinuses, sample from the sinuses. And from there, we were able to identify the likely cause. So immediately, the anti-COX was also started. And the infectious disease expert assisted significantly with the medications, advice on which type of medications to give him, to place him on. Then we have physiotherapists also come into play to really do those physiotherapy sessions for him. So those are how we were able to sort him out. So
That's wonderful,
and
because
then
it is such a great summation of how we work together, and must always be reliant on our colleagues for this multimodality. It's a wonderful summation. Raji, we are at the end of our hour of time. Would you like to say any final statements to our audience?
Yeah, what I would want to say is exactly what you tried to mention now. No man is an island, and no man has a monopoly of knowledge. As young people, since these are the bulk of the audience, we need to reach out to colleagues, work together as a team. The bigger the team that is functional, the better. So, and in cases like this, it's quite exemplary. The aim is to get the patients to the best possible, have the best possible outcome through collaborative work. Thank you so much.
Oh, thank you so much. And Dr. Lowe, I want to thank you for your wonderful work on this talk and moderating function. I want to thank everyone from FIENS. There are, I'm glad to say, more and more questions, and what we'll try to do is answer them on our website with Raji's help over the next week as we review the other questions that have come in. I want to thank everyone today for this wonderful virtual visiting professor program from FIENS, and mostly Raji, thank you very much for the kindness of your time, Dr. Lowe as well, in helping us each to learn a little bit today. Thank you.
Thank you so much. My pleasure.
And Jeannie, thanks so much. We will conclude the web at this time. Thank you.